Good evening, everyone. Thanks for joining us this evening. Tonight, I have the great pleasure of introducing Dr. Jeff McCurdy, and he's going to present to us the power of the microbiome. Before I do that, I just have a couple of slides to go through. On behalf of the Canadian IBD Nursing Board, we'd like to take a moment to acknowledge the Indigenous people of all the lands that we are joining in from today. While we meet today on a virtual platform, we recognize the importance of the lands which we each call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that call this land home. As many of you know, the webinar this evening is hosted by CanIBD. And CanIBD is a consortium of nurses across Canada working in the field of IBD and is supported by Crohn's and Colitis Canada. Our vision is to ensure people of all ages living with IBD in Canada receive high-quality clinical nursing care within a multidisciplinary team. We're committed to improving the quality of care for people living with IBD by providing mentorship and learning opportunities to IBD nurses in Canada, such as what we're providing tonight, creating opportunities for networking and sharing of best practices, developing and adopting nursing guidelines and standards for IBD nursing in Canada, and elevating the profile of IBD nursing in Canada. So this evening, I have the great pleasure of introducing Dr. Jeff McCurdy. Dr. McCurdy did his gastroenterology training in Halifax, so I had the great pleasure of working with him as he went through his residency. He's also received his PhD in immunology from Dalhousie and his medical degree from the University of Ottawa. And again, he completed his gastroenterology training at Dal and his advanced fellowship in IBD at the Mayo Clinic in Rochester. He is co-chair of the IBD Update, co-editor of the journal IBD Today, and was selected as the Canadian Association of Gastroenterology Visiting Professor of the Year in 24-25. His research interests focus on identifying predictors of disease-related outcomes in IBD, including perianal Crohn's disease, infectious exacerbations of IBD, and venous thromboembolism. Before we go on, I'd like to thank all of our current sponsors here tonight, especially Faring, who has been generous in their sponsorship of this evening's program. So without further ado, Jeff, I will stop sharing my screen and leave it up to you.
Okay, thanks, Barb. And I'm going to share my screen if I can get it working.
While you're doing that, just a quick housekeeping. We will address questions at the end of the presentation. And please, if you have questions throughout, just put them in the chat.
Okay, here we go. So again, thanks so much, Barb. And so for those of you who don't know, Barb and I were great buddies when I was doing my my GI training. And so I learned a lot of my IBD in my early phases from her. So it's nice to be here. Thanks, everyone, for the invitation. So today we're going to be talking about the power of the microbiome. And so this is a talk that we really don't hear much of, but it's becoming more and more important. And there have been some great advances even just recently. So we'll talk about some of these. So here are my disclosures. So the objectives of our talk tonight are, one, to understand the role of the microbiome in overall health. We're going to explore the relationship between the gut microbiome and C. diff infections. We'll recognize the implications of C. diff infections, particularly in our patients with inflammatory bowel disease. And then finally, we'll talk about the current management of C. diff, recurrent C. diff, and the potential of a microbiome-based therapeutics approach. So I thought we would start off with a case presentation, and this is just to kind of get us warmed up, thinking about the cases where we would think about C. diff and the treatment approach. and we'll talk about some of the controversies in this area. So this is a 61-year-old male with ulcerative pancolitis. He was diagnosed in 2014, and initially he was treated with bidirectional 5-ASA therapy. And overall, he did very well over the years, aside from a couple of flares that necessitated corticosteroid use. His baseline bowel habit is 2 formed bowel movements per day. And he was doing quite well up until September 14th, 2023, when he had an abrupt onset of watery diarrhea. And so 10 bowel movements per day. And it just so happened that 1 month prior, he was hospitalized for a cabbage. And during this hospitalization, he was treated with antibiotics for a sternal wound infection. So I think all of us have experienced these scenarios where we have patients with inflammatory bowel disease who are doing really well, their symptoms are well controlled, but then they have an abrupt onset of diarrheal symptoms. And so it's always it's a requirement for us to sort out, is this an infectious exacerbation? Is this simply an ulcerative colitis flare, or is there something else going on? So as we would always do, we performed stool studies. And in this patient, the stool testing came back for C. diff, positive for the C. diff toxin. So as a result, our plan was to use oral vancomycin for 14 days. And quite quickly after starting vancomycin, there was a quick resolution in the patient's symptoms. But so one thing that I want you to think about is, what would we do if after starting antibiotics, if the symptoms persisted? So we're going to move on in the case and see how it evolves. So a month later, unfortunately, the patient's symptoms return. So this time the patient's having 7 watery bowel movements per day. Again, there's no blood. And so quite quickly, we perform a C. diff toxin test again, and again, it comes back positive. So this time we repeat the vancomycin, but this time we elected to do a taper pulse schedule of the vancomycin. And again, the patient had a complete improvement in symptoms. And so one of the questions that comes up at this point is a second course of vancomycin, is this ideal, or do we have other options? So we'll continue with the case. So the patient over time gradually noticed that his symptoms were returning, and by February 11th, so several months after the initial or his last recurrence, he noticed that things were, not quite good. He was having 12 bowel movements per day, and now the bowel movements are bloody. So of course we rechecked for C. diff, and again, the C. diff toxin test is positive. So at this point, we elected to treat him with fidaxomicin. But after this treatment, there's very minimal improvement in his symptoms. So not at all uncommon that we would encounter these sorts of scenarios. And so the question is, what do we do now? So a couple days later, we were able to sneak him in for a colonoscopy, and the colonoscopy showed that there was continuous severe pancolitis. So at this point, we started thinking, okay, maybe it's not just C. diff, and that his infections in the past had precipitated a disease flare. And so the patient was treated with prednisone and had an improvement in his symptoms. So this is not at all of an uncommon case, and it raises a number of important questions. So one is, how do we distinguish a C. diff infection from an ulcerative colitis flare? How best to treat a C. diff infection in a patient with an ulcerative colitis flare? And maybe most importantly, is there anything that we could have done along the way here to prevent this progression? So hopefully we can address some of these questions throughout the talk. So we're going to begin by talking about the role of the gut microbiome in overall health. And I think it's important to recognize, first of all, that in all of us, our gut microbiome is highly diverse. And when I say microbiome, what I mean is the bacteria or the microorganisms that are in our gut, but as well as the products that they produce, as well as the local microenvironment. So all of this constitutes our microbiome. And within our microbiome, we have trillions of microorganisms. So in fact, if you add up all the cells in our body, the number of bacteria in our body greatly outnumber the total number of cells in our body. So in essence, we're more bacteria than human. And of the bacteria, there are up to 1,000 different species. So listed here, I don't know if you can see my cursor. These are the most common microbiota within our gut, and they include many organisms that are helpful, that promote health, and these include Bacteroidetes, Firmicutes, as well as other bacterium. And so, as I mentioned, the gut microbiome is very important for promoting our overall health. So it aids in healthy digestive function, and our gut microbiome will help to protect the mucosal surface of the intestinal tract. And one of the reasons, or one of the ways that it does this, is bacteria will produce short chain fatty acids. And these are very important. It produces a fuel source for the intestinal mucosa. And so this is one of the reasons why in our patients who undergo fecal diversion, why they can develop diversion proctitis, diversion pouchitis, or diversion colitis. And so the fecal stream, the microbiota, is very important for maintaining intestinal health. And not only that, the microbiome also protects against harmful pathogens and plays a role in shaping our overall immune system. And finally, in addition to that, the microbiome will act as a barrier to prevent the colonization of harmful bacteria. And so normally in a healthy individual, our microbiota is extremely diverse. And this diversity is important because if we have insults to our body, whether it's a chemical insult, a physical insult, a microbial insult, or even antibiotics, this will begin to reduce the diversity of our microbiome. And so normally, if we have a very diverse microbiome, our body is resilient to these various stresses and triggers. However, in situations where we're exposed to antibiotics, this will reduce the diversity of our microbiome, and we're no longer able or as equipped to deal with these various stresses. And so when we have less diversity or gut dysbiosis, this has actually been associated with a number of health problems. And these include digestive health problems, whether it be colon cancer, inflammatory bowel disease, C. diff infection, but it can also be extraintestinal diseases. So MSK-related diseases, whether it's frailty, osteoporosis, rheumatoid arthritis. A variety of pulmonary conditions have been associated with gut dysbiosis, a variety of nervous system diseases, and even cardiometabolic abnormalities. And so I'll give you an example. There have been studies that have been done where they've taken genetically obese mice, and they've taken the fecal matter from these mice and transplanted it into thin mice. And lo and behold, when this is done, the thin mice then become obese, similar to the genetically programmed obese mice. So I think this really nicely illustrates that there's likely much more to the gut microbiome than we initially felt in terms of overall health. And what's the link between inflammation and dysbiosis? And so I think, first of all, in our patients with inflammatory bowel disease, we know that in general, they have lower microbial diversity, and this is particularly patients who have active inflammation. We know that there's a reduction in the short chain fatty acid producing bacteria. And so again, as I mentioned, this is an important fuel source for maintaining the integrity of the mucosa. And then in addition to this, we know that IBD patients have increased levels of pathogenic bacteria, such as the proteobacteria, for example, E. coli. What we don't yet quite know is whether inflammation causes the dysbiosis or if the dysbiosis itself contributes to inflammation. So it's kind of the chicken or the egg story. But at any rate, we know that in patients with dysbiosis, there's an increased risk of inflammation. This can lead to mucosal barrier breakdown. And this in turn can allow bacteria to infiltrate from the lumen into the lamina propria, which will then perpetuate the inflammation. So this is an ongoing cycle. So let's talk about C. diff. So C. diff is a gram-positive spore-forming bacterium. It's anaerobic and it produces toxins. And it's the toxins that lead to the C. diff infection. So toxin A, toxin B, and a binary toxin. Now, C. diff can exist in two main forms, the spore form or the vegetative form. The spore form is what's found throughout our environment. So very common inside the hospital, but even outside in the community. And the spores are very resistant to a number of, so resistant to high temperatures, chemicals, UV light, as well as antibiotics. And so this is why even after we treat an active C. diff infection, it's very difficult to completely get rid of C. diff because the antibiotics are not going to treat the spores. So in patients who are colonized by spores, under appropriate conditions, if the spores germinate, they will germinate into the vegetative state of C. diff. C. diff will then start to produce toxins, and this will in turn lead to an infection. So what about the incidence? And the story is the incidence of C. diff, especially in Canada, is really interesting because back in the early 2000s, there was an abrupt rise in the incidence of C. diff, and particularly the incidence of recurrent C. diff infections. And then in addition to that, if you look at deaths from C. diff, there is a rapid rise in deaths. And so all of this was attributed to the hypervirulent form of C. diff that was first detected in Quebec. And so what's happened in more recent times? Well, the incidence of C. diff has leveled off, but importantly, they have remained high. And this is for incident C. diff, but also recurrent C. diff and hospital deaths. And importantly, for patients with inflammatory bowel disease, there's a number of risk factors for developing C. diff. First of all, patients with IBD inherently have a higher risk of C. diff, and this is presumably because of the dysbiosis that is inherent to having inflammatory bowel disease. But also, patients with IBD often are exposed to antibiotics, and it's known that antibiotics within 30 days will double your risk of developing C. diff infections. Now, what does C. diff do to our microbiome? So on the left here, you can see the microbiome of controls of patients who have had an initial C. diff infection and those with a recurrent C. diff infection. So in the controls, you can see high levels of the Bacteroidetes, the Firmicutes. So these again are our healthy bacteria. And then after multiple recurrences, you can see that there's fewer fewer amounts of the bacteroidetes, the firmicutes, and then you start to see more of the pathogenic bacteria, so the proteobacterium. And then if you look at the overall diversity shown here on the right, you can see that control groups who have not had a C. diff infection who have a very diverse microbiome. After one infection with C. diff, you see a reduction in your microbiome. And then patients who have had multiple C. diff infections, you have a dramatic reduction in the microbiome diversity. And so this likely contributes to the risk of recurrent C. diff. So in our patients with inflammatory bowel disease, they are particularly susceptible to recurrent C. diff infections, much more so than the general population. If our IBD patients have had one episode of C. diff, the risk of a recurrence is up to 35%. But then if patients have had multiple recurrence, their risk of further recurrence is up to 65%. And so we think that part of the reason for this is that there's a vicious cycle between the antibiotics that we use to treat C. diff, our microbiome, the dysbiosis. And so if we have a patient that has C. diff, we treat them with antibiotics. And so although the antibiotics are effective for treating the vegetative state of C. diff, it then depletes the normal microbiota or reduces our microbial diversity. And so it's this reduction in the diversity that sets up the risk for recurrence. So especially if there are spores that were not treated by the antibiotics, these spores can then germinate again and produce a recurrent C. diff infection. And so with each subsequent cycle of antibiotics, this further depletes our microbial diversity and increases the risk of subsequent C. diff infections. So we need a way in some of our patients to be able to break this vicious cycle. And so how can we restore the gut microbiome? So before we get into that, I think it's important to talk about how we diagnose C. diff, because it's not always easy. There's lots of different tests, and sometimes this can be confusing. So first of all, and I think most importantly, C. diff is diagnosed in patients who have active symptoms. So you need symptoms and a positive test. If patients don't have symptoms, we should not be doing the test. For instance, we do not do C. diff testing to confirm appropriate treatment of patients. Now, there are three main tests that are used to diagnose or to help in the diagnosis of C. diff. So we have PCR testing, we have toxin testing, and we have the GDH antigen testing, so glutamate dehydrogenase. And so each of these have pros and cons, and most labs now use a combination of these tests to arrive at the diagnosis. So in terms of the pros and cons, the PCR test, so first of all, this detects the nucleic acids of the toxigenic or the toxin genes. It's done very quickly, so there's rapid turnaround. It's highly sensitive, but the problem is it doesn't detect whether or not these toxins are being produced. So it cannot distinguish between colonization versus an active infection. The GDH, so GDH is a common antigen that's produced by both toxigenic and non-toxigenic strains of C. diff. And so this is another test that we can use. It's highly sensitive. It has rapid turnaround time, but it's not specific. So it does not distinguish between the toxigenic and non-toxigenic forms of C. diff. So this is typically used as a screening test, but it needs confirmation with a toxin test to determine whether or not C. diff is truly producing the toxin. So in terms of the toxin test, the advantage is that it's highly specific, but it's not nearly as sensitive as the GDH test or the PCR test. And so as a result, the toxin test is generally not used as a screening test because there could be false negatives. In conclusion for this part here, there's multiple tests that are done to diagnose C. diff. Most labs use a combination of each of them. And so kind of the next concept that's important to consider is how do we differentiate between an IBD flare and C. diff? And it's not easy because there's oftentimes there's overlapping symptomatology, whether it's abdominal pain, diarrhea, anorexia. If patients have a lot of bloody stool, you should think of an IBD flare, where if it's purely watery diarrhea, sure, that could be an IBD flare alone, but you also want to think of a C. diff infection. And why do we care about C. diff in our patients with inflammatory bowel disease? So this is a systematic review and meta-analysis that we did many years ago. And the first thing that we wanted to know is what is the impact of C. diff on colectomy risk for patients with inflammatory bowel disease? And so what we found is that in the short term, C. diff infections didn't appear to increase the risk of colectomy in patients with inflammatory bowel disease. Why is this? Maybe because C. diff is reversible with antibiotics. But what we did find is that in the long term, if you have a C. diff infection, this doubles your risk of colectomy. So again, in the long term. And so we're not exactly sure why C. diff impacts the long-term colectomy risk, whether it's C. diff somehow impacts our immune system, if it increases IBD activity, or if it's simply a surrogate marker for patients who have more severe IBD who are going to have be at risk of developing C. diff infections. We also looked at mortality risk, and what we found is that C. diff consistently increases the mortality risk in patients with inflammatory bowel disease. And so on meta-analysis, having a C. diff infection increased your risk of mortality by almost 5-fold. So because of this, this is why it's critical to be very aggressive in treating our patients with IBD who develop C. diff. So what are the potential treatments for C. diff and recurrent C. diff? So the most recent guidelines for the management of C. diff, and so this is in the general population, not just patients with inflammatory bowel disease. And so they suggest that we should consider whether patients have non-severe, severe, or fulminant disease. But most of us would argue in our patients with inflammatory bowel disease, this is a high-risk group, and so we should consider all IBD patients who develop C. diff as having severe or fulminant disease. So for the treatment of severe disease, we have two options for a first episode, vancomycin, and importantly, vancomycin needs to be given orally. It's not going to be effective if given intravenously. So it's given at a dose of 125 milligrams QID for up to 14 days. A second option is fidaxomicin. So both of these antibiotics have been compared in randomized controlled trials and showing that they have close to equivalent efficacy in a first episode of C. diff. But the difference between the two is that there's a lower risk of recurrence in patients who are treated with fidaxomicin. The reason why vancomycin is typically listed as a first-line treatment is cost. Otherwise, fidaxomicin could be substituted as a first-line agent. So for patients who have a first recurrence, the guidelines suggest that we should be using another course of vancomycin or fidaxomicin. However, in my practice, I do it a bit different. If a patient with C. diff has had a first recurrence, this is when I'm going to use a taper followed by a pulse schedule of vancomycin. So this means vancomycin 4 times a day for 2 weeks, then 3 times a day for a week, 2 times a day for a week, daily for a week, then every other day for a week, then every third day for a week. Now, what do we do for patients who have 2 or more recurrences? Well, the guidelines suggest here that we have the option of using the vancomycin taper pulse schedule or considering FMT. So what's the basis for FMT? So fecal microbiota transplantation. So the idea is that we harvest the stool from a healthy donor, where presumably this donor will have nice diversity in their microbiota. And this gets processed and administered to the patient who has had recurrent C. diff. And so in these patients, there's reduced microbial diversity. And our hope is that after the FMT, we can reconstitute the microbial diversity into this individual, restore a healthy microbiome, and reduce the risk of C. diff in this patient. And so if you look historically at the use of fecal therapy, it's really, really interesting. And it was actually first described back in the 4th century by an alchemist in China. And so he first described using this yellow slurry, and so a slurry of fecal matter, and he would give it to people that were suffering from food poisoning and found to be effective. And so if you fast forward many years later, in China, they started to use this type of therapy more commonly for a whole variety of medical conditions. And it wasn't until 1958 that where the first described FMT treatment or fecal therapy treatment was used for pseudomembranous colitis. And then fast forward to 2012, this is the first report of the treatment of C. diff using frozen fecal microbiota. Following this in 2013, we have our first randomized controlled trial that demonstrated the efficacy of FMT for C. diff. And then shortly after that, the first guideline recommended FMT for a 3rd recurrence of C. diff. And now more recent guidelines in 2018, the guidelines begin to recommend FMT as the treatment for a 2nd recurrence of C. diff. And so now we have a whole host of guidelines which recommend FMT for recurrent C. diff infections. And if we look at the AGA practice guidelines in particular, so for patients who have recurrent C. diff, they recommend that we determine if the patient's immunocompetent, mildly to moderately immunocompromised, or if they're severely immunocompromised. And so they recommend that for the immunocompetent as well as the mild to moderate immunocompromised, that it's reasonable to use FMT in this patient population. Whereas if patients are severely immunocompromised, and so these would be patients, hematologic patients who are neutropenic, who have undergone bone marrow transplant, or patients that are on really high dose chemotherapy, where you may want to avoid FMT. So in general, for IBD patients, I think it'd be very reasonable with our medications to use FMT. The caveat to this is that some of our newer medications that we have really not been adequately studied in this context. And so this is just to demonstrate that Health Canada now acknowledges that FMT has emerged as a therapeutic alternative for antibiotics for the treatment of recurrent C. diff infections. So how can we deliver FMT? Well, early on, it was delivered by NG tube. And so I remember trying to explain to patients that they would have to identify a relative or a friend, a healthy relative or friend. We would then have to screen the donor and the recipient for a whole host of communicable diseases. I would then explain to patients that they would need to go buy a blender, have their relative or friend collect a stool sample, then homogenize the stool sample with water, and then bring to the endoscopy unit a slurry of the fecal matter. And so after that, we would then place an NG tube. We'd have to confirm it radiologically for the correct placement. And then over the course of an hour, we would try to pour the fecal slurry through the NG tube. So as you can imagine, this is very uncomfortable for patients. It's difficult and never very fun. Fast forward years later, then colonoscopy became the gold standard to administer FMT. And so still, this is what I've used most recently. And so the same principles apply for preparing the FMT sample when we use colonoscopy. And we would perform a colonoscopy and administer the FMT into the right colon. Of course, this is invasive, resource intensive, costly, and inconvenient for patients. So if only there were other alternatives. And in fact, there have been capsules that have been developed, and then most recently, the enema formation. And so we're going to talk about the enema administration, and this is from the only commercially available product in Canada, so FMT product, and it's called Rebiota. It's been given Health Canada approval. And so Rebiota is it's a pre-packaged slurry of fecal matter from a single donor. So it's given in this enema bag, 150 ml suspension. And so there's a number of advantages to this administration. Patients do not need to take a bowel prep. They do not need to take laxatives. They don't have to fast. There's no anesthesia, and there's no colonoscopy. So from a patient perspective, this is really easy. And certainly for many patients, doing this over a colonoscopy would be preferred. So Rebiota is produced by the Good Manufacturing Practices, and we'll talk about it requires rigorous screening of their donors. Each of the donors' stool is tested for a whole host of pathogens, and a single donor stool is given for each of the Rebiota administrations. And again, this is important for tracing purposes. So here's the manufacturing process. So first of all, donors are screened and they undergo initial screening, and then every 6 to 8 weeks, they undergo screening for communicable diseases, whether it's HIV, hepatitis, syphilis, COVID, etc. Patients also undergo a health questionnaire, and each of the donations that are given are tested for over 29 pathogens as shown here. And importantly, the pathogens, not the pathogens, but the stool is not pooled between donors. So before we get into some of the data on Rebiota, I thought I would present this. This is a meta-analysis of FMT, and this is just to kind of set the stage or give you an anchor for what we should expect in terms of efficacy of FMT. And so overall, efficacy of FMT is in the 76% range, so 76% range. And there are differences between open label studies and randomized controlled trials. And so this is not anything new to inflammatory bowel disease. We see it with all of the treatments that are licensed for inflammatory bowel disease. When it's a randomized controlled trial, we see lower efficacy, and in open label studies, we see higher efficacy. So in the open label studies with FMT, generally we see success in 80% of patients, whereas in the controlled studies, around 67%. So here is the pivotal phase 3 PUNCH CD3 trial. And so this is the pivotal trial that led to the approval of Rebiota for patients with recurrent C. diff. And so in this study, they included 267 patients with documented recurrent C. diff infection. Approximately a third of patients was their first recurrent episode, whereas 2/3 had multiple recurrences. So the treatment protocol is that the investigators gave antibiotics for all patients. So we treat the vegetative form of C. diff. Following that, there's a washout period. So you want to get the antibiotics out of your system for 24 hours to 72 hours. And then in this study, patients were randomized 2-to-1 to receive either Rebiota or placebo. And so the primary endpoint was at week 8, and it was treatment success, meaning there wasn't a recurrence of C. diff. For those patients where there was a recurrence, they could receive an open label dose of Rebiota, and these patients were then followed for 6 months. So here's the results. Patients who were treated with Rebiota, 70% of the patients had treatment success compared to 57% of the patients in placebo. And when you think about it, this is not a true placebo because all patients received antibiotics. And so there's a 13% placebo-adjusted delta, which, in other words, a 30.8% relative risk reduction in C. diff recurrence. And importantly, for those patients who achieved success, when you follow them up to 6 months, 90% of patients had sustained clinical remission. So that demonstrates the durability of treatment. And so what about those patients who had a relapse? So if you look at those patients and you factor in that they received a second course of Rebiota, overall, 83% of patients had success with treatment. Now, there's always the question about the optimal method of administration of FMT. And so this was an open label study, a phase 3B study that asked the question, well, how effective would Rebiota be if we gave it by colonoscopy? So this is a small study, 41 patients who received open label Rebiota via colonoscopy this time. So again, patients were treated with antibiotics. There was a washout period. Then in this case, patients underwent a complete bowel preparation followed by the administration of Rebiota via colonoscopy. And so here are the results, 95% success rate. So really staggering results. Does this mean that a colonoscopy is better than enema? Again, this is an open label study, so we have to keep that in mind, whereas the other studies were randomized control. So this doesn't quite answer the question, but it looks very promising. Now, what about the safety of Rebiota? So this is pooled data across 5 prospective studies, and it looks at side effects at different time points. So 0 to 2 weeks, 2 to 4 weeks, and so on. And so you can see that there are increased side effects of Rebiota compared to placebo. And this relates to mild abdominal pain, nausea, flatulence. And this would be expected when giving a fecal sample to a patient. But the good news is that these transient adverse events were only there for the short term and they did not persist over time. Now, a question comes up, what do we do with our IBD patients? Is it safe to give FMT in our IBD patients? And I would argue yes, because there's actually been studies to show that FMT may improve disease activity in patients with ulcerative colitis. So this is a systematic review and meta-analysis of 4 clinical trials that assessed the efficacy of FMT for active ulcerative colitis. And what you can see on meta-analysis is that patients who received FMT were over 2-fold more likely to have a clinical response, were almost 4-fold more likely to be in clinical remission, and almost 3 times more, or almost, yes, 3 times more likely to be in endoscopic remission if they received FMT. So this is promising that FMT might even make inflammatory bowel disease better. So what does the future hold for FMT? Well, a variety of conditions are being studied, whether it's ulcerative colitis, checkpoint inhibitor associated colitis, IBS, graft versus host disease, as well as a whole host of non-gastrointestinal conditions. So it'll be very interesting to see the results of some of these studies. So in conclusion, I hope that by now you can appreciate that the gut microbiota has an important role in maintaining health. I hope you can appreciate that C. diff is one of the most common healthcare acquired or associated conditions. And it's especially a problem in our patients with inflammatory bowel disease who are more susceptible to C. diff infections and have a high risk of mortality or a higher risk of mortality compared to our IBD patients without C. diff. I hope you can appreciate that there's this vicious cycle related to C. diff, the antibiotics we use to treat it, and the resulting dysbiosis that occur. Antibiotics are the first-line treatment for C. diff, but unfortunately, this doesn't address the underlying changes or dysbiosis that occur with both C. diff and antibiotics. So restoring a healthy gut microbiome is increasingly recognized as being important to prevent recurrence. And so finally, multiple guidelines recommend the use of FMT for second or subsequent recurrences of C. diff. So I will leave it at that. Hopefully you enjoyed that and happy to take any questions.
Thank you, Jeff. Can you hear me okay?
Yeah.
Great presentation. There is one question in the chat looking at fidaxomicin, whether it's covered by ODB. I'm not sure what ODB is. Ontario
Drug Benefit. So
benefits.
So I have been able to get it covered for some patients, but I think that these patients have it's after failure of vancomycin. It's now easy to get vancomycin covered. I remember when I first started practice about 10 years ago, it was extremely difficult, and we would fight and fight. And the only thing we could get first line was metronidazole, but there had been a change. Vancomycin is now covered, but fidaxomicin, very difficult to get. So I typically don't use fidaxomicin.
One of the questions, here's another question from Usha. Is there an option of fecal transplant earlier in the treatment for UC patients?
Yeah, so it's a great question, and it really makes sense, because if you think about it, these patients, high rates of mortality, and may impact that long-term colectomy risk. So we have to think of these patients as being susceptible, and at high risk, and we need to treat these patients aggressively. So some of the guidelines do suggest that we can consider in high-risk patients, although it's not spelled out entirely what that high-risk group is, considering FMT early on. And so if in terms of rebiota, if we can get coverage for it, or if the patients are really keen to do FMT with an identified donor, I think it's fair game to do a FMT up front. Now, oftentimes when you discuss this with patients, FMT is not overly appealing with their to patients after their first with their first episode of C. diff. So it's not until they have a recurrence where they realize, oh, geez, this is a problem. I don't want this anymore. That patients are more apt to undergo FMT.
That was one of the questions that I had written down, Jeff. In your experience with FMT, what is the patient's initial reaction to the idea? Even if this one thing to have a colonoscopy and have it administered for you, but to administer it yourself, maybe some people would find that more relaxing in the presence of their own home. But I'm thinking about the idea of a fecal donor and them doing it themselves. Have you what's kind of conversations are because we haven't done it I haven't done it in Halifax. There had been a couple of FMTs performed, but very, very few that I'm aware of in Halifax. So we don't have this conversation, or I'm not having that conversation. How does that go? How do you
Yeah, no, it's a great question. So first of all, FMT is a game changer. And so it's a game changer with a condition that can be very serious, can result in colectomy, can result in death, especially with that hypervirulent form of C. diff. So FMT has become an important treatment for these patients. Now, as I was mentioning, the discussion about FMT. So typically I tell patients that that C. diff is very difficult to treat. We'll use antibiotics, but keep in mind that we may in the future need FMT. And again, the reason for that, in our IBD patients, recurrence rate after a first episode is 35% up to 40% in some patients. Even in non-IBD patients, recurrence rates are up to 20% or more. So it certainly does happen. Oftentimes when I mention that first FMT, patients are disgusted and they say, no way. But as soon as they have that second recurrence, oftentimes I will have patients, begging, come on, let's do it. I don't want this again. My C. diff infection was horrible. And so after subsequent infections, it's a much easier story. And when you talk about the data and the recurrence rates, and you explain to patients about how every time we give them antibiotics, even though it's treating C. diff, you're actually affecting the rest of your microbiota. You're reducing that diversity. And again, you get into that vicious cycle. Once you start to talk about that, patients come around to it. The So I've done a lot of FMT, but I must say, it up until recently, it is a huge pain in the ass. I hate it when I get consults for FMT. It's uh, and the reason for that is there's so much work involved. So in getting all of the testing done for the donor and the recipient, and it's kind of awkward. And the reason it's awkward is because I don't have an established relationship, a patient-doctor relationship with the donor. And so I have to order all of these tests on the donor. And what do I do if the testing comes back positive for something? And that has happened numerous times. And so I have to contact the patient and ask if I can talk to the donor, and then ask the donor to speak to their family doctor. And it's just it's a huge nuisance. And so when I heard that Rebiota was had approval in Canada, I mean, this is going to be a game changer for us. This is a product that can be administered by any healthcare professional in a monitored setting. It does have to be in a monitored setting, but I mean, very easy. Patients, just an enema that's instilled over minutes. Very, very easy. Patients are going to remain there for 15 to 30 minutes after the administration. Then they can go home. So I think this is a game changer, and the fact that patients no longer have to go out and buy a blender, have their either a family member or a friend give them a stool sample they blended in a blender that they've bought at Costco, and then bring it into the endoscopy unit. Um, that was certainly a barrier for patients.
Absolutely. Usha is saying that some patients are very accepting of FMT as they see it as a natural therapy. Not sure if you can see the chat there, Jeff. And Rachel's wondering where in Ontario, other than obviously in Ottawa where you are, can FMT be done? Is it multiple centers? Usha, I think they were doing it at McMaster. Yes.
So
Maybe? Or
McMaster,
just
yeah.
in clinical trial, was it?
Yes, so, and great points, Usha, and I completely agree. Some patients like the idea of being able to restore the natural diversity in their bowel rather than repeated antibiotics. So I completely agree. McMaster has been in inflammatory bowel disease, kind of the one of the world leaders in spearheading research into FMT. So they, of course, had the first trial in ulcerative colitis that was led by Paul Moietti. And now there's a really interesting trial that's being done by Niraj Narula, looking at the role of FMT as a treatment for patients with recurrent pouchitis, which, when you think about it, is likely if there's when you think about it, pouchitis is so heavily dependent on that microbiota, that dysbiosis in the pouch. So I mean, these studies are needed, especially for pouchitis. And if it can allow our patients to avoid long-term courses of antibiotics, that would be fantastic. So Niraj's study, I think they're recruiting about 50 patients, and they're around 45. So it's almost completed recruitment.
That's wonderful.
So there was a question, I think, about where can it be administered?
Yeah. Yeah, where? In Ontario.
It can be administered in any healthcare setting. Could be administered in office, endoscopy unit, private clinics. The the question will be how it's covered, how it's reimbursed, and that may determine where it can be given.
Hmm. Hmm. I'm just looking at the time. I think we could probably talk about this for another half an hour for sure. On behalf of CAN IBD, I'd like to thank you for your presentation this evening. Thank our sponsor, Fairing. There will be an evaluation once you close the window. Thank you for all your participation tonight. It's been a long day here. I'm getting a little tongue-tied. And I hope you all have a great evening. Thanks a lot, Jeff. It was a great presentation.
Thanks, Barb, and thanks everyone for coming out. It was a great pleasure. Take care.
Take care.